Good morning. And on behalf of the Medicare Mental Health Workforce Coalition, I want to welcome everybody to today's congressional briefing on the Mental Health Access Improvement Act. My name is Richard Yep, and I'm the CEO of the American Counseling Association. Today, our goal is to provide you with the information about providing access to mental health care for seniors, persons with disabilities, and our nation's veterans. So to achieve this goal, we want you to know more about S828 and HR 432 and how this could benefit your constituents. And frankly, we hope that your boss will support this bill. So in addition to hearing from those of us who work for professional societies, we wanted you to hear from a mental health counselor, marriage and family therapist, and a senior who is negatively impacted because of the current Medicare regulations. The Mental Health Access Improvement Act will increase access to mental health care throughout the country, including rural areas where most professionals working in mental health are mental health counselors and marriage and family therapists. The coalition is very appreciative of Senator John Barrasso and Senator Debbie Stabenow for sponsoring this briefing and for working to increase access to mental health care for our nation's seniors and veterans. So we have packed a lot of information into this time that we have together, and we want to be able to answer any questions you may have. So let me now introduce my colleague who serves as the president and CEO of the National Board for Certified Counselors and Affiliates, Dr. Kylie Dotson-Blake.
Thank you, Rich.
Goodbye.
Yes. Hello, and as we get started, we wanted to tell you a bit about who we are as a coalition. The Medicare Mental Health Workforce Coalition is a group of national and state organizations that together represent thousands of mental health and addiction disorder professionals, clients, and health service stakeholders who are committed to strengthening Medicare beneficiaries' access to mental and behavioral health care, building the provider workforce that U.S. communities need, and modernizing the coordination of delivery and payment systems for that care. Our coalition, as you see on the screen, is comprised of many different organizations and that represent these different entities and groups and partners across the spectrum. All of our work happens in these diverse spaces. At the heart of that work is a deep and abiding commitment to expanding and strengthening mental health services for the most vulnerable in our society. We represent professionals who are prepared and committed to that service, and we represent clients and stakeholders who recognize the urgent needs in this area. Our coalition has been collaborating on the Mental Health Access Improvement Act for over a decade, and organizations in the coalition that represent professionals that include mental health counselors, marriage and family therapists, are organizations like ACA, the American Counseling Association. You just heard from Rich, and my organization, the National Board for Certified Counselors. And others, the AMCA, the American Mental Health Counseling Association, and Mft and Mfts. These that represent the marriage and family therapist. In addition to the organizations that represent the professionals, our coalition also includes member organizations that represent a diverse range of stakeholders and communities that powerfully support the need for strengthened access to mental health care by Medicare beneficiaries because their stakeholders live that need every day. Groups like the Association for Behavioral Health and Wellness, which represents health plans, and the Michael J. Fox Foundation for Parkinson's Research, which represents some of the patients impacted by the Medicare mental health treatment gap. Our coalition also includes organizations like the National Council for Mental Wellbeing and its Centerstone, who represent behavioral health clinics, where the need for additional professionals is truly felt by clients and the community. This diverse group of interests and the interests that we hold represent a wide scope of people who are impacted by the need for counselors and marriage and family therapists to be able to be recognized and participate in the Medicare program. The Mental Health Access Improvement Act has received bipartisan support and also significant recognitions by organizations serving the Medicare population and organizations recognizing the important impact of the health of this population on our communities and families, including the Western Governors Association, the Bipartisan Policy Center, and AARP. We appreciate your time today, and we are very pleased to be able to have this opportunity to come together for this important discussion. At this time, we'll be having we will transition to a word from one of our very esteemed co-sponsors.
Hi, I'm Senator John Barrasso from Wyoming, and I want to thank you for the opportunity to visit with you today. As members of the American Counseling Association, you do amazing work to help patients each and every day. And this COVID-19 pandemic really took a toll on the mental health of our entire country. Your commitment to meeting the needs of your communities is important, and it's greatly appreciated. Improving mental health care is a bipartisan priority. Right now, our Senate Finance Committee is in the middle of drafting comprehensive mental health legislation. As a doctor who practiced in Wyoming for over 2 decades, improving mental health is personally important for me. In particular, I am passionate about making sure patients in rural America have access to the care that they need. That's why I'm so proud to have introduced the Mental Health Access Improvement Act, and I did it along with Senator Debbie Stabenow from Michigan. Now, all of you know about the importance of this bill. The legislation allows counselors and marriage and family therapists to receive reimbursements from Medicare. This will greatly expand the ability of seniors to get the mental health care that they need. Our goal, of course, is to get this legislation across the finish line this summer, but we need your help. The American Counseling Association has some great resources that can help you make your case. For example, you can point out that this bill would increase the available mental health workforce by more than 200,000 additional providers. You can also talk about the importance of treating mental health conditions earlier. This ultimately will save money for our entire healthcare system. Most importantly, make sure that members of Congress understand how this legislation will make a difference for your patients. Your personal experience and your perspective is the best tool to impact the decisions made by Congress. Thanks again for giving me a chance to visit with you today. Together, we can get the Mental Health Access Improvement Act passed into law and improve health care for seniors all across our nation. Hi, I'm Senator John Barrasso from Wyoming, and I want to thank.
Sorry about that. Excuse me. This is Jay Eberly with Senator Barrasso. Thank you very much for joining us today, and just wanted to take a couple seconds to talk about the bill and offer myself, and Amy's going to speak in a few minutes from Senator Stabenow's office, as a resource so we can answer any questions that you might have about the legislation. Improving access to mental health care, as Senator Barrasso pointed out, is really important in Wyoming and, of course, in Michigan, and I would say in rural America across the country. As you have conversations with stakeholders in your states and in your districts, you should ask them, how are your community mental health centers delivering care in rural parts of your areas? And I would say in Wyoming, especially, we rely on mental health counselors and marriage and family therapists to deliver that care. And so this legislation is something that's been a long-standing priority for Senator Barrasso. It's something that we introduced since he came to the Senate over a decade ago, and we're continuing to support the bill. So Amy's going to take a few minutes and talk a little bit about the Senate Finance mental health process that they're going through right now, and I look forward to answering your questions. Thank you.
Thanks, Jay. So the senator is really happy to be working with Senator Barrasso on this, and it's great to be working on this bipartisan issue. She's been working on behavioral health for a long time, so it's also great to just see all the attention and that's been getting in Congress this session. So we're really excited about that. So in addition to improving patient access to care, as we've heard, this is also really important for the workforce issue. So Senator Stabenow is working with her colleague Senator Daines on the workforce working group in the Senate Finance Committee right now, putting together a behavioral health package. So this is a priority for her in that space as well. And it was great to hear from so many advocates in the process of responding to the request for information that really emphasized this bill and the benefits it would have in communities nationwide, both for patients and for improving the workforce shortages we know are really chronic in the behavioral healthcare space. So we're really looking forward to continuing to work on bipartisan solutions through the Senate Finance Committee and with other colleagues as well to find solutions to improve behavioral health care. And the senator is excited to submit this as a priority for her in the finance behavioral health package. And as Jay said, more than happy to be a resource for any questions that come up on this bill, and feel free to reach out to us, and I'll pass it off to Dr. Ferguson so you can hear from some clinicians.
Good morning. I'm Dr. Donna Ferguson, and I work for the Department of the Army. I serve as the Chief of the Behavioral Sciences Education and Training Division. So, as a clinical mental health counselor, we can provide so many different diversities, but 2 points I really want to be able to speak to this morning is why is it important to seniors, persons with disabilities, and veterans to have access to mental health care by LMHCs and LMFTs. And those 2 points are accessibility and affordability. Our LPMHCs and MFTs are 1/3 of the mental health profession in terms of providing clinical mental health support to our nation's seniors, persons with disabilities, and our veterans. And I know our veterans firsthand, working within the Army for the last 22 years. All LMHCs and LMFTs, they're specialized in mental health counseling and they're approved in TRICARE. Not all social workers are trained or qualified to conduct or perform duties of clinical mental health. A large portion of them provide case management work. And also a large number of our psychologists perform duties such as psychoeducation and psychological assessments. Not all are actually doing clinical mental health counseling. And I think it's important to see the role that our clinical mental health counselors play. Our seniors need social support, which our counselors are trained to work with family systems from a mental health perspective. Our qualifications and standards are rigorous. Our training is centered around clinical mental health. We also ensure no counselor is released to work without having submitted to clinical supervision. So these things are critical. But when we talk about accessibility as well, a large part of our nation is rural, and seek mental health support is challenging for them. And we've already discussed this. And so our counselors can do this, but also telehealth is critical advancement, which we also provide by saving time and money for our Americans that are out there in those rural areas as well. And so that I can turn this over to my colleagues to continue this discussion, I would finally say you wouldn't be compromising quality mental health care by having us. You would be affording accessibility and also affordability to those who need it the most. Thank you so much. And I turn it over to Dr. Fullen.
Hi there, it's good to be with you this afternoon. My name is Dr. Matthew Fullen. I'm an assistant professor in the counselor education program at Virginia Tech. I'm going to share with you some research that we have done on the impact of Medicare mental health inaccessibility. So first, current Medicare regulations allow psychiatrists, psychologists, clinical social workers, and psychiatric nurses to provide mental health services. However, this list of providers was last updated in 1989. And in the 33 years since that update, the mental health marketplace has changed dramatically. As was previously mentioned, there are over 200,000 licensed professional mental health counselors, licensed marriage and family therapists who stand by ready, willing, and able to provide services, but are currently not approved to do so under the Medicare program. And as was mentioned, this is roughly 35 to 40% of the behavioral health workforce that Medicare recipients currently don't have access to. So our team at Virginia Tech, including my colleague Jordan Westcott, who's on the call, has conducted a series of research studies to identify the current prevalence and impact of the Medicare mental health coverage gap among members of the counseling profession and among Medicare recipients. After surveying nearly 6,000 American Counseling Association members, we found that roughly 70% of practicing counselors had been impacted by the Medicare mental health coverage gap, including about 50% who reported turning away Medicare recipients who were seeking mental health care, as well as 39% who described having existing clients who would become eligible for Medicare during the course of mental health treatment, either due to age or due to disability. And these counselors having to then make some really challenging decisions about referring those individuals to another professional because they could no longer work with them due to the exclusion from the Medicare program. We've done additional research with Medicare recipients to look at how they view this issue directly. One woman, Sheila, 60 years old, disability eligible, lives in a rural area and currently is unable to find a Medicare eligible provider to take her insurance. And she told us it's incredibly frustrating. You feel angry and despondent and even more depressed. You're already dealing with depression, and then you have to fight through your own issues just to get on the phone to try to find a provider. And because of these policy issues, there simply isn't a provider to be found. And she said on some days you just feel like you want to give up. Mary, 69 years old, age eligible for Medicare, who lives in the suburbs, she said, you know, I had to discontinue therapy because I was having to pay out of pocket. My Medicare insurance didn't provide the services that I needed. And a year later, I had an emotional breakdown. I wasn't able to access mental health care. I ended up being in the system, being diagnosed with major depressive disorder, and spending time in hospitalization. And all of that may have been prevented if I hadn't had to pay out of pocket and could have continued my counseling. Susan, age 57, also disability eligible, also living in a suburban location, said, it's incredibly frustrating and demeaning when you're on Medicare and you can't find mental health services. It's tiring and exhausting. You're already feeling hopeless and helpless. You're getting all of these no's and no callbacks because it's so hard to find a provider who's eligible and able to take Medicare. And she put it this way, you know, if you're on Medicare, if you're a Medicare recipient, that means that you're older or you're disabled. And that means that you're a population that is already vulnerable socially, economically, and emotionally. And she said, as a country, we can really do better than this. We should make it easier for people to find mental health services. Now, we talked to providers as well and conducted interviews to find out what their perspective was on this issue. And we found that, you know, one person told us in community mental health, one of the most heartbreaking things I see as a provider is when a client transitions from Medicaid to Medicare. I can work with them under the Medicaid program, but for some reason, as soon as they become Medicare eligible, I can no longer see them. Another provider, Brandon, who's the director of a behavioral health unit in a federally qualified health center in rural America, says, I meet monthly with community private practice providers. There's just not enough of them to go around. And so Medicare recipients are particularly burdened because half of our providers in our community just can't see them. Michelle, a licensed counselor who works in private practice, told us, I have a caseload of people with severe mental illness, including schizophrenia. They'll come to me, they'll work with me. We do really amazing work together, but then they become Medicare eligible. And I have to tell them I can't see them anymore because of the Medicare coverage gap. And some of these individuals end up not being able to find another provider and end up in the hospital. And friends, hospitalization is something that, you know, serves a real purpose, but that is not a cost-effective and not the most humane way to provide services. We can address this continuity of care issue that so many providers and recipients have acknowledged by passing this legislation and allowing for continuity of care and allowing for this 40% of the behavioral health workforce to be recognized by the Medicare program. And with that being said, I'm going to hand things off to my colleague, Dr. Kelly Roberts, a licensed marriage and family therapist and director of graduate programs in human sciences at Oklahoma Christian University.
Thank you so much, Dr. Fullen. I'm sitting here internalizing all of this data and feeling like I'm living what he's talking about right now. I just want to thank so much congressional members and your esteemed staffers that are here today, our visitors, our guests, our colleagues, because we have an important story to share, and I appreciate your time in sharing it with us for us to tell that story. As a therapist who has worked on this issue for 18 years, normally what I do when I talk about this issue is talk in broad points. I share the stories, the history, data, and finally those solutions, because that's important just to get the awareness going. But today, I'm going to share my experience that I normally don't share for being a therapist for 20 years. And I feel like for this conversation for today, that's the most important way I can contribute. I once treated a Native American elder who was grieving because he had to give up ceremonial dancing. I sat in a chair next to his hospital bed every morning for a month, providing therapy as he went through surgeries to amputate both feet and eventually his legs because of diabetes and an uncontrolled bone infection. In addition to suffering an acute depressive episode and medically related anxiety, he was suffering from historical trauma and losses of family members. I processed childhood stories of running away from Indian boarding schools in attempts to find his family. We worked through his loss of ceremonial dancing, and I helped him reduce his anxiety about close spaces for each of his imaging trips down the hall. When I saw this gentleman wheeling himself into the clinic for follow-ups, months later, he thanked me for the good therapy medicine and told me he was doing much better. I did not tell him that we documented but never billed for those services. I once responded to a medical emergency from an adolescent patient. She had intentionally overdosed on sleeping pills and alcohol in a suicide attempt. I worked shoulder to shoulder with the ER docs, encouraging her to quickly drink this charcoal treatment that she desperately needed to protect her liver and save her life. Just as she got it all down, she immediately threw it back up, and at the same moment, her aging grandparents walked into the ER and witnessed this event. The visual was like a horror movie with black, thick liquid covering the screaming child. Her grandparents were so shocked and panicked from what they witnessed that I had to tag team with a PA so that I could respond to their crisis. I provided family therapy, including the patient's grandparents, for several weeks after that crisis session, helping them work through their own trauma responses and begin preparing for how they could best support their child. Those same grandparents also got to witness their grandchild graduate from high school and go to college. But the treatment they received through that process, though it would have been covered by Medicare, was never billed because they only wanted to work with me after the suicide attempt, having formed a therapeutic alliance from the support they received at the hospital. I've treated rural elders who were alcoholics or addicted to opioids, making the decision to enter rehab, and elders in metropolitan settings who were wasting away from anxiety due to being extorted by family members who had drained their bank accounts. I've treated elders with eating disorders, PTSD, BPP, OCD. I've consulted with family physicians on how to treat gerontological patients who've been married for over 50 years but had to be separated by levels of care for medical reasons. All of these services were medically necessary and were provided by a skilled therapist working within the scope of their practice. And all of these services should have been covered by Medicare. None of them were. And yet, my pro bono work is not the primary point I'm here to make. Licensed counselors and family therapists work full-time, providing the same array of services to persons up to the ages of 64 years and 364 days. But an arbitrary red line suddenly stops us from doing what we are trained to do at midnight on a patient's 65th birthday. I now lead a new training program for students who aspire to become licensed marriage and family therapists. My students don't really comprehend what it currently means to have their future license go unrecognized by the United States Medicare system. They only understand right now that they want to make a difference, promote healing, and pass the national boards exam. They definitely worry about that. To Congress, colleagues, guests, I want more than anything to look my clinical students in the eye and finally tell them that, yes, you have chosen a noble and honorable and worthy profession. Yes, you will have difficult cases, excuse me, that at times will make you question your vocational choice. But I want to really tell them also, yes, when you diagnose, treat, and assist a Medicare recipient in reaching their goals, you will be recognized as an independent, qualified provider for the work you do. I want to tell them the real story of how laws adapt to the evolving needs of society. And I desperately want to do that before I turn 65 and have a need someday that can't be met unless it's from another one of the altruistic 225,000 yet exhausted licensed mental health providers who are still waiting to be recognized by Medicare. Thank you.
Good morning, everyone. My name is Brian Banks. I am the Chief of Government Affairs and Public Policy Officer for the American Counseling Association. I have the honor of introducing you to Ms. Darla York. Darla is a resident of Miami County in Ohio who knows the effects firsthand of what it's like to be wanting to be seen by a mental health counselor, but being denied because of her age. Darla?
Thank you very much for having me. I feel a little humbled in telling my story. Let me first give you a little information about myself. My name is Darla York. I am chronologically 71 years of age, but I often think I'm only 36. In my earlier life, I was married, raised one biological child, divorced, helped to raise two stepchildren, worked as a school psychologist for 6 years, and taught elementary children for 30. Today, as a retired senior, I volunteer for an agency that helps all people who need help with utility disconnects, birth certificates, IDs, work boots, and clothes for employment. I also, in this agency, help seniors who are struggling to get their needs met. I am a court-appointed special advocate, or a CASA, which is a person who is the voice for children who have been taken from their home or put under protective supervision by Child Protective Services. And in my spare time, I also teach parenting classes for court-ordered parents whose children are currently on probation. Now, as I said, I was a teacher. I had excellent insurance through my employer. Through that insurance, I was able to provide the excellent medical coverage for my husband, who was diagnosed with dementia at age 54. He never made it to Medicare. And my son, who was diagnosed with bipolar at the same time. I also was able to see a psychotherapist for almost 15 years to help me cope with the many changes that were occurring in my life. At age 61, I went into a clinical depression that lasted 3 years. My therapist was with me all the way and even helped me to enter a wonderful mental health facility close to Cincinnati. As I was approaching 65 in Medicare, however, my therapist informed me that she would not be accepting Medicare as payment. I did not want to give up this wonderful therapist who had helped me through so much. So I agreed to pay out of pocket, but would only be able to meet with her once a month or as needed. It was perhaps 2 years later that my therapist closed her office due to health issues. I tried to find another counselor who might accept Medicare, but found it very difficult. I tried to find them through various means. I am somewhat proficient with the computer, which a lot of 71-year-olds are not. When I found one that would accept Medicare, I found that they were no longer taking new patients and that I had to be put on a waiting list. I never did receive a call from any of these counselors. During the last part of the pandemic, I began to experience some mild depression due to relationship issues and sought again to find a therapist who would accept Medicare. Again, I found it difficult to find one and never really did. I went online, which is not always easy for seniors to navigate, and then had to accept a telehealth session. And while I understand that telehealth can be very effective, I was not able to connect to the link that they sent me. And after a half hour of trying to connect with the therapist, I became discouraged and did not try again. I have several senior friends who have gone through some traumatic events, either with the loss of relationships with spouses and or children or other friends, and wanted help dealing with their part in the loss or just help adjusting to aging. They found it difficult to connect with a therapist that would accept Medicare. These seniors are on a fixed income and they can't afford to pay out of pocket. Many therapists that do accept Medicare only counsel via Zoom or telehealth. Again, it is effective. However, seniors were not raised with computers and they have a very difficult and also a very fearful feeling towards looking at someone on a monitor. Technology is very scary to many seniors, and they are faced with more and more technology when they have to use an iPad to check into a doctor's office, set up a patient portal, and fill out and sign health history on an iPad. If they do not have a younger person to help, they want to avoid rather than seek help. They do not want to find a counselor they only see on the monitor. They're lonely, they're alone, and they crave a face-to-face. Another problem that many seniors face is that they are choosing a counselor who may be years younger than them, and they do not feel that these young counselors can relate to their issues. To date, I do not have a counselor. I am, however, fortunate to have counselors and psychotherapist friends my age and semi-retired willing to talk with me when I am in need. As I said, I am fortunate and grateful, but many, oh so many seniors do not have this. I could go on and on perhaps, but this has been my story. Thank you for your time and allowing me to tell it.
Hi, everybody, and thank you so much, Darla. That was really a very powerful testimony about the need for modernizing the Medicare program. I'm going to be talking, I'm Christine Blackwood, I'm with Arnold and Porter, and we represent the American Counseling Association. I'm going to be talking about the some of the details of the bill and what the bill would do, and answer some of the questions that we've heard from folks on the Hill. So the goal of this bill is really pretty simple. It's, as you've heard, it would allow licensed professional mental health counselors who are defined in the bill, and licensed marriage and family therapists also defined by the bill, to serve Medicare beneficiaries at annual rates that would be set by CMS as part of the annual physician fee schedule. We truly believe, and as you've heard, that people who are covered by Medicare, which Senator Barrasso alluded to, need to get help sooner rather than later. And Darla is a great example of that, so that they can stay out of the hospital in more expensive settings and retain maximum functionality and independence, the kind of thing that we all want as we age. And we've also heard about the market forces demanding that we adapt our models of caring for older adults and provide more cost-efficient and cost-effective alternatives that address the supply and demand imbalance and provide a broader range of choice and competition in the Medicare program. So why do we need legislation? That's what we've heard a lot of people ask. Why can't CMS just do this on its own? Well, the Medicare statute actually specifically defines who can be a provider of mental health counseling services. Currently, only psychiatrists, psychologists, psychiatric nurses, and licensed clinical social workers are designated as being expressly permitted to submit bills to the Part B program for diagnosis and treatment of mental illness. Yet other payers, such as private insurers, most Medicaid programs, the VA to some extent, and other employer insurance, cover services by these practitioners who represent 40% of the professional mental health workforce. However, if you're seeing, as Darla has pointed out, and as Dr. Fullen has talked about, if you're seeing a counselor or marriage and family therapist for diagnosis and treatment services, and you turn 65 and go on Medicare, you cannot continue to see your counselor unless you pay out of pocket, which many folks on fixed incomes cannot afford to do. This obviously is disruptive to the continuity of care. It makes no sense given that these practitioners are already billing at lower rates, and they are very often located in areas of the country where there is a dearth of other mental health professionals available. So how does the bill constrain the expansion of the program and create the creation of more accessibility for beneficiaries? Well, as you heard from Senator Barrasso, there are immediate and long-term savings from providing the type of preventive services that can keep older adults healthy, functional, and better able to manage their physical health conditions and keep them out of more expensive settings. But also, the bill is drafted in such a way that it has very precise requirements. Any counselor or marriage and family therapist seeking to enroll in the Medicare program must be licensed in their state specifically to provide these types of covered services. They must hold a master's or doctoral degree in their field, and they have to have at least 2 years of directly relevant clinical supervised experience before they would be able to see Medicare patients. Also, the Medicare rate is set in the bill. It's tied to the rates that are paid annually for psychologists under the Medicare program. They're tied to the same rate that licensed clinical social workers are paid at under the fee-for-service program every year, which is 80% of the lesser of the practitioner's actual charge for his or her services, or 75% of the annual rates that are set for payment of psychologist services. And as with most Part B services, the beneficiaries are responsible for a 20% copay, some of whom will be able to pick it up through their Medicare supplement insurance. The Medicare program also generally requires that all services are medically necessary and reasonable, and the Medicare program would have the option to, like many private insurers, place limits on the total number of sessions allowed for a beneficiary. And while it is very important, and it's wonderful that many counselors and marriage and family therapists want to serve this vulnerable population, and we want and need them to, not all counselors and marriage and family therapists are in private practice. Some work in schools, they work in colleges, they may work for the VA, they may work for an employee assistance program, or in other settings where they don't ordinarily see private patients. So, and as Dr. Fullen mentioned, the last time that Congress revised the Medicare statute to address a mental health workforce shortage that we had then was 1989, the year that the Berlin Wall came down. That was when Congress recognized that clinical social workers had the training and qualifications to provide counseling service to Medicare beneficiaries, and allowed psychologists to see Medicare beneficiaries outside of community mental health centers. And obviously a lot has changed in the last 33 years. We have invested in and developed a highly trained professional mental health counseling workforce, and the Medicare eligible population has substantially increased and continues to do so as older adults live longer and face more medical complexity, and also are facing, in some cases, substance use and mental health challenges on top of physical complexity and medical challenges. And we are facing, as we all know, critical shortages of mental health professionals, particularly in rural areas. So this is a bill that really makes a lot of sense. The level of need has never been greater. And if your boss is not already on this bill, if you're a staffer, I would urge you to really take a look and ask your boss to sign on as a co-sponsor and join us in getting this long-needed common sense measure passed into law in this Congress. Thanks very much. And I'm going to turn it over to Dr. Beverly Smith.
Hello, everyone. My name is Dr. Beverly Smith. I am the president and interim CEO of the American Mental Health Counseling Association. I have over 26 years of experience as a clinician. I'm a licensed professional counselor, a national clinical certified mental health counselor, and I'm also a national and state approved clinical supervisor. On behalf of the Medicare Coalition for Mental Health, we would like to once again thank you for being here with us today. A special thanks again to Senators Barrasso and Senators Stabenow for sponsoring the Bipartisan Mental Health Access Improvement Access Act, as well as Representative Thompson and Keiko for their work on the companion bill HR 432. We would also like to thank all of the congressional offices that attended today. We would encourage you to reach out to any member of the coalition if you have any questions at all. Once again, we would like your support in helping to move this bill to passage during the 117th Congress. Your action will help thousands of Americans to have access to needed mental health care. Again, thank you on behalf of the Medicare Mental Health Workforce Coalition.
Good morning again, everyone. At this time, we will take questions. If you have any questions, please feel free to chime in or drop it in the chat, and our speakers will be happy to answer them. Thank you so much. While you're thinking about your questions, I think I'd just like to jump in for a second and ask a question of our clinicians, just from, and anyone can take this, just from your experience, when you're talking to your colleagues in the field, do you have any stories or advice from your colleagues of how they have worked with Medicare eligible clients when they've approached them or were not able to see them any longer?
I can take that. Normally, the advice is, what's your bank account look like? You know, and unfortunately, that is usually what the conversation centers around, because if we're already working with someone who is aging into Medicare, they don't want to leave right in the middle of their treatment. I will say with our colleagues, all colleagues, especially I believe LPCs and LMFTs, network greatly. And what we do is we have groups of chats where we try our very best to get someone in as quickly as possible. We work together. It's almost like this underground railroad of mental health care. And I know that's a powerful metaphor for a lot of people, but it's also a powerful metaphor for us to try to find our Medicare recipients the care that they need. There aren't a lot of solutions. We're working the best we can with the possible solutions, but normally it means going to that person's church and asking if they can support their care by paying cash for them.
Thank you for that answer. I'd also like to let everyone know during the session, we dropped a few links into the chat. What you'll find is a Medicare Brief, which gives you the background and history of the Medicare program as it pertains to licensed professional counselors and marriage and family therapists, and the contributions they can make to the program. We also dropped in a link to a survey that was released of over 24,000 licensed professional counselors, trying to find out how many of them would enroll in the program and how many of them, quite frankly, will not enroll in the program and the reasons why. So that link is in the chat as well. And earlier you heard from Kylie, who gave an explanation of who's in the coalition. We have every member of the coalition listed, as well as their charge and a link to their websites. We have a question that just came in, and the question is asking, I'm not sure who it's from, but would the bill allow Medicare coverage for counselors who don't have the Lmhc or Lmft license? What about LPCs? Let me start off quickly, and I'm going to pass this over to Dr. Fulling. LPCs, licensed professional counselors, is also the same term used for licensed mental health counselors. In the counseling profession, each state has the authority to decide which title they are going to give the counselors. For the sake of this argument, we're using the term mental health counselor as it is listed in the bill. So Dr. Fulling, again, would the bill allow Medicare coverage for counselors who do not have the LMHC or LMFT license?
Yeah, that's a great question. And as Brian mentioned, each state navigates that licensure process, and sometimes the terminology differs state to state. We see that same thing. Some states it's a licensed clinical social worker. Other states it's a licensed independent social worker. That does not create issues in terms of Medicare reimbursement because should this legislation be passed, there would be a rulemaking process that would clarify some of those details and make sure that individuals who are licensed in their states and who have a scope of practice that matches what the Medicare legislation is putting forward would make sure that those are in alignment. So it's certainly not something that professionals should be concerned about because the goal of this bill is to get well qualified, get the right people available so that Medicare recipients can have their mental health needs met.
Thank you, Dr. Fullen. And also, I want to let everyone know on the call, this coalition has the ability to really narrow down to the states that you live in. So if you would like state-specific stats of what is happening with mental health care as it pertains to seniors and disabled, as well as veterans, we can share that with you. Just give us a call at the number you see on the screen or shoot us an email and we will happily obtain that information and provide it to you. So while we have a few minutes left, I want to ask Darla a question. Darla, you gave a compelling story, and you and I had an opportunity to talk about your friends and people that you associate with that have very similar stories. Can you share any additional information about what you are seeing in Miami County with your friends and your colleagues?
Well, as I said, I volunteer at the agency that helps people. And we also have a caregivers program in this agency. And there is an 87-year-old man that I've basically adopted because even though I'm a senior, he's more senior than I, and he has no family. He has no one. And he does not know how to navigate the system very well. He gets like $1,400 a month to live on. In his rent, he lives in a very, very small place, is $450. Well, I've recently taken him to the doctor and he's going to need hearing aids in both ears. And I'm not sure that the Medicare that he has is going to pay for those hearing aids. And he's very concerned about that. And he says, I'll only put it in one ear if that's, if that's all I can afford. But he also, I need to get him a life alert. And his nurse tells me that Medicare that he has will not pay for the life alert. And he'll have to pay $40 a month for this. So I'm trying to find ways to get him these things without having him pay anything out of pocket. But we have so many people that are on fixed incomes, and that's why they come to our agency. So many of the seniors come and we give them what are called taxables, so they don't have to pay out of their pocket for like toilet paper, paper towels, shampoo, and things like that, because they have health issues and they're having to pay co-pays that are really astronomical to them because of what they bring in every month. I don't know, the mental, a lot of these people are so lonely. They want companionship. They just don't know where to go to get any help. And, the gentleman that I'm helping, he says, oh, I've been depressed my whole entire life. There's not a day goes by that I'm not just depressed. And I try to talk to him. No, I'm not going to take any medicine. I'm not going to go talk to anybody. There's a lot of pride, I think, sometimes with the seniors of the seniors. And so they just live with their mental illness. And it's unfortunate. I don't know that I've answered your question, Brian, but
Darla, that was a great answer. And I really appreciate that. I read a stat recently, I believe it was through SAMHSA, that stated that once a person gets to the age closer to 85, they begin to think of having or committing suicide because of the reasons you just stated, the stress and anxiety. And many seniors have stated that it's just normal when it really isn't normal. But the reality is that they live with it, unfortunately, and they want help, but the help, unfortunately, in some cases is not there because of their access to counselors, their lack of access to counselors and marriage and family therapists. We have a few more questions, and it's 11:50, so I'm going to try to get through these fairly quickly. The first I will be happy to answer, and it is, who stands in opposition of the bill, and what is the primary argument against this bill? Well, the good news is there isn't anyone that stands against this bill. We've had psychologists, social workers, AARP, the Western Governors Association, the Bipartisan Policy Center, and more in support of this bill the past several Congresses. And so there isn't any opposition against the bill. The challenge that has been faced in the past, prior to the 117th Congress, is the cost. This bill the CBO score for this bill is $1.2 billion over a 10-year period. So if you look at the big picture, it's not an extremely expensive bill to add in licensed professional mental health counselors and marriage and family therapists. Again, ACA did a study. You can find it. The link is in the chat. And also we will send everyone on this call the link about who will actually join into the Medicare population as a provider and who will not. And we receive some really great information there, and we go into cost savings. So we'll be happy to share that with all of the attendees on this call. The next question we have, and let's see here. The question is, how would you describe the differences between counselors and MFTs, and why are both important to add to Medicare? Dr. Roberts, would you like to take this question?
Sure. Thank you, Brian. So I think the distinction is important to share, that there are similarities between all licensed mental health providers, including even psychologists, social workers, licensed professional counselors, family therapists. We all have a core foundation of basic training that needs to be completed. But every single discipline subspecializes and specializes in a little bit different area so that the distinction can then cover more of the population and the emerging needs that we've delineated over research and practice over the last 30, 50 years. So I would say the primary distinction between a professional counselor and a marriage and family therapist is the theories that they approach and some of the practice paradigms. Family therapists tend to see a little bit more individual in relation to the family, individual in relation to the groups, lots of children in families, and certainly lots of elders in families. And so if you can imagine that an elder needs care, just like Darla was explaining, there are many, many isolated elders, and LPCs are so well suited for that. But they work hand in hand with family therapists who many times wrap around a service so that an elder can get better faster, so they can facilitate a different kind of care. And so it's basically two distinctions of much of the same work, but working hand in hand to get the care quicker and do a better job of covering it much more less expensive than certainly hospitalizations. I hope that's enough of a distinction, but I'm glad to respond offline again for more of delineations and distinctions if anyone would like.
Thank you for that answer. The next question we have comes in from Jacqueline Williams-Reed, and I'm going to pass this question to Christine. How long would this process take to roll out FPAST? Christine?
Thanks, Brian. There's no precise answer, but estimated perhaps 2 years, perhaps more. It depends. As Dr. Fullen was saying, the agency CMS would, if this bill passed at the end of this year, the agency CMS would have to engage in rulemaking to define some of the parameters that and how the program would be implemented. There would also obviously be a period of time when both Medicare beneficiaries and the counselors and marriage and family therapists who are interested in enrolling as providers in Medicare would need some education and understanding about what the rules are. So to estimate, it would probably be take a couple of years to really implement the program, and then hopefully we see more people taking advantage of these benefits over time.
Thank you, Christine. I appreciate that answer. We have time for one more question, and this question is going to go to Dr. Donna Ferguson. And Donna, the question is one that many would think is simple, but we would love to hear your answer. Can you tell us why this issue is important to the Army, to the DoD, to the military, including counselors as well as marriage and family therapists in the Medicare provider program?
Absolutely, Brian. This is actually paramount to the military as well, because inside the Department of Defense, you'll find psychologists and social workers. It is a rarity to see a licensed mental health professional. And as you've seen, we've had challenges within DoD with such areas as suicide, depressions, anxiety. So all these different areas as well. And this is a space where there are very few of those in our profession. But not only that, when you think about our nation that has been at war for more than 15, 20 years, and when they become veterans and they move into this space as well and seeking care, there's a shortage of care for them externally also. And being 1/3 of this mental health or behavioral health profession, these licensed mental health professionals, these counselors can be able to be a bridging strategy to become a solution to some of the problems that we're actually having. So it's extremely critical. I think I was just reading a report just yesterday while down at Norfolk, where there were 4 suicides, and they talked about the shortage of psychologists and social workers. But mental health professionals, our counselors, are equipped and qualified to be able to fill this gap, to be able to stand in and ensure that we take care of our nation's military and our nation as a whole.
Thank you, Dr. Ferguson. I think this is a great point to end on. Again, thank you everyone for joining us. And if you have any questions, feel free to contact us. We will be in touch with each of you with the links that we posted into the chat today. Thank you so much and have a great day. Goodbye, everybody.